Today, the Department of Pediatric Dentistry and Pediatric and Preventive Dentistry will be conducting the 33rd Dental Combined Round. The speaker of today's DCR will be Dr. Marunal, third year resident, and Dr. Muskan Rathore, second year resident. The session is moderated by Dr. Reema Sharma and under the guidance of our respected head of department, Dr. Anand Gopal Nigam sir. The topic of today's presentation is complete oral rehabilitation and space management in a 6.5-year-old child. So now I would like to hand over the stage to Dr. Marunal to commence the session.
Thank you, Dr. Kushbu. Good afternoon, everybody. Today we present a case of complete oral rehabilitation and space management in a child of 6.5 years. The case is of a 6.5-year-old male child named Advik Jain. The patient is a resident of Kota and the case was done in the year 2025. Coming to the chief complaint, a 6.5-year-old boy reported to the Department of Pediatric and Preventive Dentistry, Mahatma Gandhi Dental College and Hospital with the complaint of multiple caries teeth in the upper and lower jaw since 2 years. History of present illness. According to the parent, the child developed blackish discoloration on the upper and lower left back teeth, which has gradually increased in size over time. There has been recurrent history of pain on chewing in the upper and lower left back tooth region and upper right back tooth region. There is no history of swelling or pus discharge, no sensitivity to hot, cold or sweet foods, no bleeding from gums, along with a positive history of food lodgement in the affected area. The child has no difficulty in chewing, swallowing, speaking or sleeping. There are no medications or home remedies given for the same. There is no history of trauma to the teeth, no oral habits such as thumb sucking, lip biting or mouth breathing, and the child's general health, appetite and growth are reported to be normal. No relevant medical history of delayed milestones, systemic conditions, trauma or allergy was given by the patient. This was the patient's first dental visit and there is no history of previous dental treatment or any complications experienced. No relevant family history of systemic or congenital conditions or delayed eruption of teeth was obtained from the parents. The patient reported normal bowel and bladder functions. The child consumes 3 main meals daily plus 2 to 3 sugary snacks daily. He frequently eats chocolates and sticky sweets in between the meals. He also has the habit of drinking sweetened milk before bedtime without brushing afterwards. His sleep pattern is regular, with him experiencing a consistent, uninterrupted sleep of 8 to 9 hours daily, which is indicative of optimal rest. No deleterious oral habits were reported or observed. Coming to the general physical examination, the patient had an ectomorphic build with a normal gait. The vitals were present within the normal range. The patient's height was 3 feet 3 inches and he weighed 25 kgs with a BMI of 24.7. There was absence of any pallor, icterus or cyanosis. Coming to the extraoral examination, we observed that the patient's head shape was mesocephalic with a mesoproscopic facial form. We observed that the patient's head shape was mesocephalic with a mesoproscopic facial form and a straight facial profile. There were no signs of facial swelling, asymmetry, abnormalities in the eyes, nose, skin, lips, chin or teeth. The lymph nodes were not palpable as well. Coming to the intraoral examination, during the soft tissue examination, the buccal mucosa appeared pink in color and was moist with a smooth texture. The tongue exhibited a normal pink color with normal papilla size and shape and no abnormalities were detected. Additionally, no abnormalities were observed on the floor of mouth. Upon hard tissue examination, we found out that there was a complete set of deciduous dentation present in the oral cavity of the child. These are the grossly decayed teeth that we found. There were smooth surface caries with respect to tooth number 53, 63, proximal caries with respect to tooth number 75, occlusal caries with respect to tooth number 85, 55, 65, 74 and 84, and all the upper and lower anteriors were untreated. Also, there was no mobility present in any of the tooth. There was no abnormality detected in the hard palate as well. However, the patient's parent did not proceed for the treatment at that point and reported for the treatment after a span of 3 months. These are the hard tissue findings after 3 months. The findings are pretty much the same, the only difference being the pre-exfoliation mobility observed in the upper and lower anteriors. These are the pre-operative photographs of the patient. The first one showing maxilla and then second one showing mandible. The investigation that we advised to the patient was an orthopentamogram. This is the OPG image of the child. The OPG was done on the first visit. Coming to the management, this is the treatment plan that we formulated for the patient, which includes composite restoration with respect to tooth number 5-3, 6-3, 7-3, 8-3, 7-4 and 8-4. Pulpotomy with respect to tooth number 8-5, which is to be followed by stainless steel crown. Pulpectomies with respect to tooth number 7-5, 6-5, 5-5, which are also to be followed with the stainless steel crown. Extraction with all the upper and lower anteriors, and extraction followed by space maintainer with respect to tooth number 5-4 and 6-4. Extraction was advised with respect to tooth number 5-4 and 6-4 as these teeth were so grossly decayed that they couldn't be restored. But the space left by the extraction of these two teeth couldn't be left as it is, as it would lead to space loss and interfere with the eruption of premolars. Hence, to preserve the space, a space maintainer is advised in these cases. Now, can anybody tell which type of space maintainers or appliance can be given in the anterior region after the extraction of upper and lower anterior teeth?
RPD?
Yes. Removable partial denture or a Groper's appliance can be given in these cases. Removable partial dentures are not much popular in pediatric patients because of poor compliance. Hence, we did not consider this as an option. Talking about Groper's appliance, it is a fixed appliance used as a space maintainer and anterior aesthetic replacement in young children which has composite resin teeth or teeth-colored agraric buildups to replace the lost incisors. The appliance has to be continuously monitored before the eruption of permanent incisors and the plate has to be removed accordingly. In our case, as the patient was a resident of Kota and couldn't come for routine follow-ups here, so we did not go ahead with this option as well. This was about the anterior region. Can anybody tell about the space management in the posterior region? Any appliance used in the posterior region?
Tandem loop,
Yes.
transpalatal butterfly.
Yes. These are all the options for space maintainers that can be used in the maxillary arch. Talking about the Nance palatal arch, these may be used in maintaining the maxillary first permanent molar positioning when there is bilateral premature loss of primary teeth with no loss of space in the arch. This type of space maintainer, however, can only be given after the eruption of first permanent molars. And also, the palatal vault in this patient was very high, which is why we did not go ahead with this type of space maintainer. The next one is transpalatal arch. This appliance is designed to prevent the molars from rotation. The best indication for transpalatal arch is when one side of the arch is intact and several primary teeth on the other side are missing. In our case, there was bilateral multiple loss of teeth, which is why we did not go ahead with transpalatal arch as well. The next space maintainer that we see here is the band and loop space maintainer. It is usually indicated for preserving the space created by the premature loss of single primary molar with band adaptation done on the adjacent molar. In our case, the adjacent molars, that is tooth number 5-5 and 6-5, were to be treated endodontically, followed by a crown and hence couldn't be banded, which is why we avoided this space maintainer as well. The next one that we see here is a band and bars type of space maintainer. This usually prevents the eruption of premolars and it was used in earlier times, which is why we did not consider this as an option. The last one that we see here is the crown and loop space maintainer, which is similar to the band and loop, except that a stainless steel crown is used for the abutment tooth instead of the band. This was the highly acceptable space maintainer in our case and hence we chose to go ahead with this one. These are the treatments that was performed in the patient. Pulpotomy with respect to tooth number 8-5. A formocrosol pulpotomy was done in this case. Pulpectomies with respect to tooth number 75, 55 and 65. The obturation here was done with zinc oxide eugenol. Now let us move to the steps in crown preparation. The procedure begins with the occlusal reduction done with the help of a pear-shaped burr. The occlusion is reduced by about 1 to 1.5 mm uniformly along the cuspal structure so as to create a reduced tooth but with the same occlusal anatomy. The reduction is determined by comparing the marginal ridges of adjacent teeth. The next step here is the proximal reduction. This is done with the help of a tapering fissure burr and needle burrs with the main objective of breaking the contact. The objective is to produce near vertical reduction with the gingival margin of the preparation to be of feather edge without any shoulder or ledge formation. The first picture that we see here shows the trimming of the excess crown. After placing the crown, with the help of a scaler, a scratch can be made around the gingival margin on the crown or marked with a glass marking pencil. The scratch line indicates the gingival line and the gingival contour as well as the portion of the crown to be removed. Next, smoothing of the edges with finishing burrs is done. The next step in adaptation is to contour the crown with the help of pliers so as to reciprocate the original contour of the tooth. Contouring is done with the help of number 114 Johnson's contouring pliers. The next step here is crimping, which is very important for the supporting tissues, as a poorly adapted crown will serve as a collection point for bacteria, contributing to recurrent caries or incipient periodontal diseases. Using number 417 crimping pliers, the crown is crimped in the gingival third. After the contouring and crimping is complete, the crown is retried and with an explorer, all the margins are checked for adaptation. And this is how the final fit of the stainless steel crown looks like. Coming to the fabrication of loop, the first picture shows the initial loop formation. Next, with the help of 3-prong pliers, a curve formation is done. This is how the marginal adaptation of loop looks like. The retentive band of loop is formed in this way. This is the complete loop placement. And this is how the final presentation of polished space maintainer looks like. Coming to soldering, the first picture that we see here is of stabilization and the next one is of soldering. A generous amount of flux should be applied above and below the point where wire contacts band. A piece of solder is transferred to solder joint with a pair of utility pliers. The flame is redirected towards the cast and the joint is heated till it is red hot and the solder flows evenly. This is immediately dipped in water and appliance is removed. A finished solder joint should be smooth and free of porosity, and this is how the finishing and polishing is done. This is the final presentation of the polished space maintainer. These are the post-operative photographs of the patient. This image shows the pre-operative and post-operative photographs. Now I call upon Dr. Muskan to proceed with the further maintenance and discussion part.
Good afternoon, everyone. Coming to the maintenance, the dietary guidance advocated here can improve general as well as dental health. The daily ingestion of a balanced diet and varied selection of foods from the different food groups, avoidance of sweets that are retained next to tooth enamel, and discontinuance of between meal snacking are the basic elements in achieving a diet that produces few caries. Next, recall visits, that is follow-up visits after 3 months to check for proper retention, cleaning, and checking for cement loss for space maintainer. The erupting permanent first molars are indicated for application of pit and fissure sealants due to high caries index in the child. Children below 8 years are advised to use circular scrub technique for brushing, and this was explained in detail to the patient and parents. The patient was advised to use fluoridated toothpaste. Pediatric dentistry has increasingly shifted from a conservative restorative approach towards the concept of total pediatric patient care. Thus, all aspects of oral health care, including diagnosis, prevention, oral medicine, restoration, and correction of malocclusion, have increasingly become the responsibility of the pediatric dentist. The guidance of the eruption and development of primary and permanent dentition is an integral part of pediatric dentistry, and it should contribute to the development of a permanent dentition that is in harmonious, functional, and aesthetically acceptable occlusion. Space management is an important aspect of treatment for a pediatric dentist, as inadequate space management can cause problems which are long-lasting and severe. The premature loss of primary teeth may cause loss of arch length, resulting in crowding of the permanent dentition, impaction of permanent teeth, aesthetic difficulties, malocclusion, and other problems. The definition of space maintainer, according to Boucher, is a fixed or removable appliance designed to preserve the mesiodistal space created by the premature loss of a primary tooth or a group of teeth. While the term space maintenance was coined by J.C. Brower in 1941, which is defined as the process of maintaining a space in a given arch previously occupied by a tooth or a group of teeth. The indications and contraindications of space maintainer are indications when there are signs of closing of space after the premature loss of deciduous teeth, if the eruption of permanent tooth will take 2 years or longer, to avoid supra-eruption from opposite arch. The contraindications are if the radiograph shows that the succedaneous tooth will erupt soon, 1/3 of the root of succedaneous tooth is already formed, and the succedaneous tooth is absent. Coming to the band and loop space maintainer, it is a unilateral, non-functional, passive, fixed appliance indicated for space maintenance in the posterior segments when single tooth is lost. These are some of the modifications of this conventional band and loop space maintainer. As in our case, we have used crown and loop space maintainer. It is also a modification of this band and loop space maintainer. Crown and loop space maintainer is similar to band and loop, except the stainless steel crown is used instead of band on the base tooth. It is an excellent choice if the tooth needs to be restored. The appliance incorporates a crown on the second primary molar with a soldered wire loop extension extending forward to come into contact with the distal cervical surface of the primary canine in the quadrant. The loop uses 0.036 or 0.040 inch stainless steel wire. This wire is strong enough to withstand the biting forces while ensuring a rigid abutment contact and stopping forward movement of the second primary molar and the distal movement of the primary canine. The wire design approximates the gingival contour of the extraction space to avoid occlusal interference and is wide enough to allow the permanent tooth to erupt. The advantages are its durability. The crown provides full coverage and protection for the abutment tooth, especially if it is heavily decayed. Dual function acts both as a restorative crown and a space maintainer, reducing the need for two separate appliances, prevent tooth drift, effectively maintains space for the eruption of permanent teeth, avoiding orthodontic complications. Improved retention. Since the crown is cemented, it offers better stability than band-type space maintainer, and its long-term use can remain in place until the eruption of the permanent successor. The disadvantage is a little bit costlier than the conventional band and loop space maintainer. It is technique sensitive and the aesthetics of the child. This is an article published in European Archives of Pediatric Dentistry by M.A. Quadiment, who compared the success rate and longevity of band and loop space maintainer and crown and loop space maintainer. So according to them, the majority of band and loop space maintainer fails over time because of decementation of the band, while crown and loop space maintainer had shown success and longevity compared to these conventional space maintainers. The take-home message is comprehensive caries management in pediatric dentistry combines early detection, early intervention, and proactive space management to ensure optimal oral health and proper dental development. Primary teeth, hence, maximum efforts are directed to restore and preserve the natural teeth as far as possible. Primary teeth play a key role in maintaining arch length, guiding the eruption of the permanent teeth, supporting normal function, and act as a best space maintainer. The use of a space maintainers prevent drifting of adjacent teeth, loss of arch length, midline shifts, and potential malocclusion. It helps maintain the integrity of the dental arch, supports the proper eruption sequence of permanent teeth, and reduces the need for complex orthodontic treatments later. Thank you all.